the organizers to invite me. So I don't have financial interest in this talk. So more than 220 million people worldwide have diabetes. In 2005, it was estimated that 2.2 million people will die each year between 2005 to 2030. After 15 years of diabetes, approximately 2% people will become blind and 10% people will develop severe visual improvement. Diabetic macular edema is a leading cause of loss of vision. Approximately 1 million in USA and 21 million worldwide people are affected by diabetic macular edema. DME occurs in 20 to 25% of all diabetic patients without diabetic retinopathy. Diabetes is estimated to reach 300 million worldwide by year 2025. Prevalence of diabetes expected to rise more than 50% globally from 2000 to 2030. Prevalence of diabetes is higher in blacks and Hispanics than in Chinese or whites, including some genetic predisposition as well. Prevalence of DME vary country-wise. In USA, overall prevalence of diabetic macular edema was 11.1% in younger people, and overall prevalence of diabetes was 8.4% in older people, and 25 years cumulative incidence of DME was 29% in type 1 diabetes. In UK, prevalence of diabetes was present in 6.1% to 6.4% in diabetics. The macula is a special area at the center of the retina, the light-sensitive layer of tissue at the back of the eye. As we read, light is focused onto our macula. 3 million of cells change the light into nerve signals that tell the brain what we are seeing. With central vision, we are able to read, drive, perform all activities that require fine, sharp, and straight-ahead vision. There is scant extracellular space. Most of the space between neural cells is packed with glial element, and retinal hydration is closely regulated. The correct state of hydration is critical for retinal transparency. Normal physiological functions of retina are regulated by outer blood retinal barrier, inner blood retinal barrier, role of vasoactive factors, and vitreoretinal interface factors. So DME occurs mainly as a result of disruption of blood retinal barrier. Fluid is accumulated within the intraretinal layers of the macula. Hyperglycemia is a major risk factor for development of diabetic retinopathy. Chronic hyperglycemia leads to the formation of advanced glycation end products and AGEs inside diabetic retinopathy and maculopathy. So AGEs found at the vitreoretinal interface and internal limiting membrane. Their receptors are attached to the foot plates of the molar cells, and recent advances suggest that AGEs can cause structural alteration of posterior hyaloids that strengthens the vitreomacular adhesion between the posterior hyaloid and ILM. In this, the macrophages, produce growth factors, and the macrophages produce cytokines. They in return causes vasoconstriction, and they activate platelets. So disruptive blood retinal barriers play a pivotal role, alter vitreomacular interface, hypoxia, altered blood flow, inflammation processes, vascular endothelial growth factors, endothelial dysfunction, leukocyte adhesion, and reduced pigment epithelial cell derived factor, increased protein kinase C production, and vascular permeability upregulation. So these are the vasoactive factors: vascular endothelial growth factor, protein kinase, histamine, angiotensin, matrix, metalloproteinases, pigment epithelial derived factor, and platelet derived growth factors, and basic fibroblastic growth factors. And today I have learned few more. Posterior vitreous detachment and posterior cortical vitreous, thickened and taut posterior hyaloid, macular traction in the proliferative diabetic retinopathy, and role of ILM and role of vitreous gel, vitreous hemorrhage. These are all causing DME. So the co-morbids of diabetic retinopathy are hypertension, hyperlipidemia, neuropathy, fatty liver, and now the depression is very important, and I think the researchers will find some factor which causes depression also. So health is a very complicated issue. It doesn't make 2 and 2 4. So risk factors are type of diabetes, duration of diabetes, control of diabetes, and smoking, anemia, pregnancy, alcoholism, and lifestyle and obesity. So diabetic macular edema is diagnosed stereoscopically as retinal thickening in the macula using fundus contact lens on the slit lamp. Accumulation of fluid within the intraretinal layer of the macula because of disruption of blood-retinal barrier, vasoactive factors, and vitreoretinal interface factors. So it shows the fluid in the intraretinal area. So there are 3 forms of macular edema: focal macular edema, diffuse, and mixed one. So there is an OCT classification of DME by kg, and there is a no thickness, normal macular morphology and thickness, and subclinical macular edema, no clinically detected retinal thickening exceeding more than +2 standard deviation for central macula, and established macular edema, retinal thickening, and clinical evident morphological characteristics of edema. So there is a very important role of OCT in DME. It gives you a fundamental diagnostic imaging technique, essential complement of ophthalmoscopy and fluorescein angiography, technique of choice for early detection of preclinical macular edema, and helps to understand anatomy of DME and intraretinal damage, assist in patient selection with DME who can benefit from the treatment, identify what treatment is indicated, and precise monitoring of treatment response. Now in future, the Doppler OCT provides non-invasive assessment of retinal blood flow in the diabetic patient, and OCT angiography demonstrates even more capillaries in pericentral macula than conventional FFA, and allows visualizing separating superficial and deep capillary plexus. And future role of OCT in detecting preclinical diabetic macular edema is quite evident from above innovations. So central thickness of normal healthy individual is measured by OCT is 212 microns, and early retinal thickening detected by OCT cannot be seen by ordinary slit lamp biomicroscope examination because this OCT works as an optical histology. It shows optical histology. 25% cases of subclinical macular edema seen by OCT remains undetected on clinical examination. And when center point thickness of 225 to 299 micron present on OCT. Conventional practice is observation without treatment. And photocoagulation is indicated with when clinically significant macular edema is present. So no edema involving the center of the macula, center of the fovea as observed by the slit lamp, but with center point thickness on OCT of at least 225 micron, but not less than equal to 299 microns. So progression of diabetic macular edema is defined as increase in the center point of at least 50 microns to more than 299 microns. So the facts are that the chronic macular edema causes substantial damage to the vision. In routine cataract surgery, transient macular edema develops, and chances of macular diabetic edema increases with existing comorbids and risk factors. Edema does not resolve at its own in diabetic with hypertension. So what is the problem and what are the issues? Despite these known facts, ophthalmologists are treating cataract and diabetic maculopathy without identifying and addressing comorbids and risk factors. Because if an ophthalmologist sees cataract, he removes cataract. If he sees some macular edema, he gives laser. So instead, we all treat only symptoms, signs of the disease through surgery and laser therapy. Rarely we act as interventionists to attack the cause of the disease and prevention before the cure. So my basic message is that we should prevent the macular edema before it occurs. So diabetes is an endocrine entity having multifactorial etiology and involves every organ of the body. So we should stop the disease process at its preclinical stage, control co-morbid risk factors as preventive measures, stop blinding cascade of diabetic macular edema at preclinical stage by early suitable intervention and counseling for lifestyle alteration. To find out effects of preventive management of comorbid and risk factors of the diabetic edema, we did a study. So inclusion criteria was either gender, age 30 years and above, type 2 diabetes mellitus, duration of diabetes more than 7 years, one or more comorbid or risk factor, and clear ocular media. And exclusion criteria was clinically significant macular edema, non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, previous history of laser treatment, previous history of intravitreal steroids or anti-VEGF, any other fundus pathology, and previous history of ocular surgery. So methodology was it was a non-randomized prospective study conducted at the Ophthalmological Department, Civil Hospital and Al-Noor Eye Hospital. Duration was, the study was from April 2013 to February 2014, and follow-up was done from on 2nd, 4th and 6th month. Two groups were made on the basis of duration of diabetes, two groups were made on the basis of macular thickness, and two groups were made on the basis of HbA1c, which will be less than 11 or more than 11. So comorbids and risk factors identified on history and investigation done at the baseline and subsequent follow-up visits. Blood pressure monitoring was done and complete blood count was done, blood sugar fasting and random was done, and glycosylated hemoglobin was checked, and lipid profile and microalbuminuria. On every follow-up visit, each subject sought expert opinion from diabetologist, nephrologist, neurologist, dietitian, and health counselor. At primary and subsequent follow-up visit, each subject was examined for clinically significant macular edema and NPDR by slit lamp microscopy, and central macular thickness by OCT. Intervention was done in our study when central macular thickness was more than 350 microns on OCT and existing comorbid and risk factors not controlled. So what intervention for the preclinical diabetic? In first line, we control of comorbid and modification of risk factors. In second line, intravitreal anti-VEGF. Third line, repeat intravitreal VEGF after 1 month when all above failed and clinical significant macular edema and NPDR developed. And fourth line was combination of intravitreal anti-VEGF and laser photocoagulation, which was the macular grid or focal laser. So this is a demographic data. In this, it is a relationship of baseline, and this is 2nd month, and this is 4th month, and this is the 6th month, and this is the summary of follow-up. In this in the baseline, the glycosylated hemoglobin was 10, and after after 6 months, it was 1.1%, and the macular thickness became from 46.6% to 9%. So in hypertension also, all the comorbid was controlled. So changes in the macular thickness in the baseline was 361. In the 2nd month it was 352, and 4th month, so p-value is very highly significant. So highlights our study that progression of diabetic macular edema is highly dependent on glycemic control. Uncontrolled hypertension and cholesterol are bad prognostic indicators and directly affect worsening of maculopathy. Early preventive intervention for control of co-morbids risk factors help in maintaining normal macular thickness. And Jocelyn study shows exponential rise of diabetic retinopathy with increased HbA1c, and HbA1c is a quality control test which determine glycemic control for last 10 to 12 weeks. HbA1c is an excellent marker for control of diabetes, and elevated blood pressure is a major risk factor for development and acceleration of DME. Elevated blood pressure is best predictor for development of severe eye disease. So appropriate blood pressure control in diabetics, ABCD trial suggested good hypertension control slows progression of diabetic retinopathy, and adequate control of hypertension is strongly recommended. So increase likelihood of lipid abnormalities in diabetic patients, and intervention to lower plasma cholesterol to less than 100 milligram has been recommended. So this is a new idea which I want to develop in my country, that the patient who comes to an ophthalmologist, he just sees the eye, and the patient have so many problems. So we only do the eye care. So we need diabetologist, physician, nephrologist, neurologist, cardiologist, and then the patient goes door to door. So this if we want to manage diabetes, we have to treat diabetes under one roof. So this is the counseling and awareness. I will not read all this, but we just check people who have diabetes since more than 10 years. They don't know what is HbA1c, and they are literally unaware, and there are many patients who are not interested in control of their blood pressure or blood sugar level. So we recommend that OCT should be done for every diabetic patient at each visit. Co-morbids, risk factors should be identified and addressed at the earliest. Intervention should be initiated if preclinical diabetic macular edema is associated with poorly treated co-morbids and risk factors. One window service should be established at each secondary and tertiary care center, and consensus documents for management of DME, consensus educational document for internists, and consensus counseling document for diabetic patients should be developed and spread. So OCT is a very useful tool which helps to identify preclinical diabetic macular edema at earliest, and DME can be delayed, arrested at early stage with good control of diabetes, hypertension, and cholesterol. Strict early management of comorbid risk factors is a key to success. Thank you very much.